So, welcome to this webinar. We will use our website recall question bank over here, which is basically recalls dating from 2011 up to our current time. And we'll take them divided by topic. So we are going to start with pediatric surgery and embryology. A lot of people have a problem with this topic. Anyone would like to read the questions, please raise the hand. Yes, please. Anyone would like to read? Okay, Dr. Ali, you can unmute yourself and read this question for us, please.
Okay, hello everyone. A healthy baby is born at home at their following birth, the midwife grant umbilical cord. Which of the following vascular units will no longer carry predominantly well oxygenated blood towards the heart? Should be umbilical vein.
Umbilical vein, your
Okay,
answer is...
I will go. I will go with ductus venosus.
Okay, let's see if this is the answer. Yes, that's the correct answer. It is ductus venosus, right? Ductus venosus, simply in this explanation, is saying that ductus venosus is a bypass channel through which well oxygenated blood bypasses the liver basically and into the inferior vena cava and from there towards the heart, right?
Yes.
And so simply, if you can see in this diagram, that's placenta over here, right? And this is the umbilical vein. It's carrying well oxygenated blood towards the baby. And here's the ductus venosus. This is the bypass channel, which is carrying well oxygenated blood, then into the inferior vena cava, then into the right atrium. Okay. Let's see the next question.
Okay. Baby shortly after birth is noted to be dyspneic and cyanosed. A plain X-ray shows that the left chest contains multiple gas-filled loops of bowel. What is most likely developmental abnormality? This is diaphragmatic hernia. Congenital. So the fairest option.
First option, it's saying a hernia due to failure of closure of the pleuroperitoneal canals. Okay, let's see the answer. Yeah, that is the correct answer. They're talking about Bogdalic hernia, right? Which is a
Yes.
defect in closure in the pleuroperitoneal membrane. Normally, this pleuroperitoneal canal, the lungs grows into it. The lungs are derivative of what, by the way?
Sorry, come again?
The lungs, they are derived from which embryological structure?
I'm not sure.
Yeah, they are derived from the foregut tube, right? They emerge as a
Yeah.
tracheopulmonary bud, you can say, and they then grow into the
Yeah.
pleuroperitoneal canals. Their growth is the one that is thought to close these canals. So the main problem,
Yeah.
why people die of this? What's the most common cause of death due to Bogdalic hernia?
Pulmonary hypoplasia.
Very excellent. So it is pulmonary hypoplasia, basically. Some people actually say that the pulmonary hypoplasia is the main abnormality. It is the primary abnormality, which then subsequently leads to the herniation of bowel and so on. So it is not due to the hernia itself usually. The cause of death is due to severe respiratory failure. These babies are born very distressed at birth. They have a scaphoid abdomen. They're, cyanosed. There are bowel sounds in the left chest, all right? Because this is mostly, as you can see here in the explanation, posterolateral and to the left. That's very important to point. Okay, let's look at the next question.
21 years old found to have situs inversus at laparoscopy. Which of the following inform the axis of rotation of the cut during embryological development? Superior mesenteric artery.
Senior configure. So option D.
Yes.
Okay, let's see. Yeah, so during gut, it is the superior mid-gut rotation. The superior mesenteric artery forms the axis. What I want you to know is the degrees of rotation. Do you see in the explanation here? They say during this process, the digestive tract elongates and undergoes counterclockwise rotation, 90 degrees. Then there is retraction of the bowel into the abdominal cavity, where another 180 degrees of counterclockwise also rotation occur. Right? That's very important to know the degree of rotation when it is coming out and when it is coming back. And also you must know at which time of gestation it will come back. Right? About 10 to 12 weeks of gestation, the midgut should return. That's so important. Okay. So if there is failure of return, that it does not completely return, what's the resulting problem?
Gastrogenesis.
No. Gastroschisis is a actual defect.
Menkels diverticulum.
No, also no.
Malrotation, I think.
Malrotation is a problem with rotation, but it is not a problem with return. Meaning that it does not return completely into the midgut.
Abdominal viscera outside the abdominal cavity is either gastrogenesis or omphalocele.
Yeah, please come again, doctor. You said something.
Omphalocele.
Yeah, omphalocele, right? Omphalocele. It's different from gastroschisis, right? Gastroschisis is an actual defect in the abdominal wall, full thickness, usually right side of the umbilicus. Is that right? And basically the bowel is just floating in the amniotic cavity when you do the anomaly scan around 20 weeks of gestation. And omphalocele, on the other hand, there are membranes. It's through the umbilical ring itself, and there are membranes covering the hernia itself, right? It may contain bowel, it may contain liver, it may contain kidneys, it may contain anything, basically. Okay, so prognosis-wise, right? Which one is worse? Okay, which one is worse? Gastroschisis or omphalocele?
Gastrogenesis.
Why?
I think it's worse.
What's the reason behind that? Why is it worse?
I can't recall the cause, but I think it's due to the membrane, the lack of membrane.
Your point?
I think without membrane,
yeah.
I think without membrane, the intestine will vaporize, and then there is a peaking necrosis.
That's good. So you actually are telling me about prognosis locally, basically on the abdomen. Meaning in gastroschisis, there are risk of necrosis of the bowel. There's risk of basically atretic segments in the bowel, right? There's risk of peritonitis. Okay, I agree with you. But what is the overall prognosis is actually better in gastroschisis, not omphalocele. Omphalocele is worse. Why? Because there's a very, very high likelihood of associated chromosomal abnormalities, like, for example, congenital heart disease, like diaphragmatic hernias, like trisomies, like trisomy 21 down or Patau, but gastroschisis is not associated with these, or very little associated. Okay, there's a buzzing sound. Okay, it's disappeared. Right? You got me? So Omphalocele is worse, not because there's complications in the abdomen, but because of the associated chromosomal anomalies that comes with it. Okay, let's see the next question.
A young mother took her newborn baby boy to the clinic with concern regarding the appearance of his face. The baby is then investigated for pharyngeal arch abnormalities. Which one of the following is associated with second pharyngeal arch? Uh, I think facial nerve.
Yeah, that's correct. I think that's correct. Let's see. Yeah, it's the facial nerve, right? So let's look at this table. Basically, that's the second arch, right? It's associated with the hyoid bone, right? With the parts of it, not all of it. The facial nerve, the cartilage is called Richard cartilage, which gives rise to the lesser cornu and the upper part of the body of the hyoid. It gives stapes. That's something very commonly asked about in the exam. It gives rise to the stapes. It also gives rise to the styloid process. You know, the muscles, all the muscles, all of those muscles simply that are supplied by the facial nerve, right? Muscles of facial expression, posterior biliofdigastric, platysma, stapedius. Okay, the artery associated with it is the stapedial artery, the second aortic arch, and the internal pouch or second is giving rise to the palatine tonsil. The external cleft doesn't give anything the second, right? The first give rise to what, by the way? First cleft, right?
Come again, the question.
The first pharyngeal clefts
The
give
first
rise,
pharyngeal cleft.
yeah,
Uh, external auditory meatus.
yeah. So it's written over here, right? It's external auditory meatus and lateral surface of the tympanic membrane. Okay, let's move to the next question.
Which of the following is embryological origin of the inferior parathyroid? Inferior is
Third what?
third pouch.
So option A, third pouch.
Yeah.
Yeah, that's correct, right? The inferior parathyroid develops in association with the thymus from the third pouch, and the superior parathyroid develops from the fourth pouch. Some people say that there's a there is a sixth pouch or another pouch, which is for the ultimobranchial body. Some people say it's no, doesn't work like that. So there's a little bit controversy about the ultimobranchial body. Okay, so the ultimobranchial body give rise to what structure?
Thyroid gland.
No, it has something to do with the thyroid gland, but not the entire. The thyroid tissue doesn't come from that. Ultimo.
Parafollicular cells.
Very excellent. Yeah. So give rise to the parafollicular cells or C cells that are calcitonin releasing, right? They originally come from the neural crest cells. Okay, let's look at the next thing.
A large posterior diaphragmatic hernia present at birth is called by which of the following?
Hmm.
C. Failure of closure of septum transversum.
Failure of closure of septum. Are you sure?
No, I'm not so sure, but
B.
makes sense to me.
B.
You want to go with B, failure of closure of the left pleuroperitoneal membrane. Okay, let's see if this is B. Oh yeah, that's correct. It's B, right? Because we're talking about this, right? Bogdalic hernia.
Oh, but God,
It is usually posterolateral, and to the left, right? It's due to failure of closure of the left, right? The left one, left pleuroperitoneal membrane. Okay, that's perfect. Let's look at the next one.
Which of the following form the floor of fossa ovalis? The floor is by septum primum, I think.
Septum primum. Okay. Yep, that's correct. It's septum primum, right? The fossa ovalis, that's the remnant of what? Of foramen ovale, right? The floor of it is septum primum. The floor is septum primum. The limbus, or the margins, that is, the limbus of the fossa ovalis is formed by the septum secundum. Okay, so you have to know that the floor is septum primum, the limbus is septum secundum. Okay. Okay. Yeah.
Which one of the following is the main embryological origin of the urinary bladder? Urogenital sinus.
Urogenital sinus. Okay, let's see that. Yes, that's correct, right? Says here the urogenital sinus give rise to the majority of the urinary bladder. Other derivatives include what? Urethra, vagina, the lower 2/3 of the vagina, prostate gland, bulbourethral gland, Skinny's gland, or paraurethral glands, that's in the females only, of course, and Bartholin glands. These are all derivatives of this structure. Okay.
Failure of closure of the pleuropericardial fold will result in which of the following events? I'm not sure in this one. Is it pleuropericardial? Pleuropericardial?
Pleuropericardial. It's not, look, there's pleuropericardial, there is pleuroperitoneal folds, and there are, yeah, peritoneal, that is pericardioperitoneal folds. They are different slightly from each other. Okay. If some people said B, some people said A, let's look at the answer. Okay, yes. So
It will be A.
yes, look, this is a rare defect. That is, the pleuropericardial defect is a rare defect. In the exam, they may ask you about, for example, if they say pleuroperitoneal, okay, or they say if they say pericardioperitoneal defects leads to central hernia, central diaphragmatic hernia defect, okay? But pleuroperitoneal defect, they are very rare, and they usually result in a fibrous pericardial defect. Now, another note that I want to highlight is that later on, they will also contribute to the formation of the pleuroperitoneal canals. So if this option is not there in the exam, you should go for poctalic hernia, because later that can contribute to it. Okay.
Okay.
Let's see this question.
A hemivertebra is derived from which of the following? The mesoderm.
Hemivertebra derived from mesoderm. Let's see the answer. Yes, so that's the correct answer. Let's see what's written here. They said vertebral segments are derived from somites, which are segments of paraaxial mesoderm. Okay, so they said the mesoderm is one of the 3 germinal layers that appears in the 3rd week, whatever. But they said there are 4, that's important. Look at this. They said there are 4 important components. There are axial, paraaxial, intermediate, and lateral plate. You need to know the derivatives of each one, just to stay on the safe side. So the axial mesoderm give rise to the notochord. You know notochord? It's famously asked about in the exam, the notochord. In the adults, right, notochord give rise to what?
Nucleus pulposus.
Yeah, excellent. The nucleus pulposus, right? in the fetus, it has what function? What does it serve? What's the purpose?
The function?
Yeah, the function of the notochord in the fetus. Now, in the adult, the notochord contains the nucleus pulposus, which is actually, you know, a very something like a gel. It's acting like a shock absorber, right? That's the function. But in the fetus, yeah, what does it do?
Neural crest migration.
That's very close, right? It helps to develop, you know, there are initially two layers. There's epiblast and there's hypoblast, right? The bilaminar germ disc. There are epiblast and hypoblast. The notochord grow from the epiblast and then in between the epi and hypoblasts. Okay? It releases growth factors. It causes thickening in the overlying epiblasts. This thickening is called neural plate. This thickening progressed to form a tube, which is called neural tube. When the neural tube closes, there are cells which are left over called neural crest cells. So it has something to do with CNS development, right? It has something to do with nervous system development. That's the function in the anyway. And the intermediate mesoderm give rise. They said intermediate mesoderm connects the paraaxial mesoderm with the lateral plates. Eventually differentiate into urogenital structures like kidney, gonads, their ducts. That was a question, by the way, in January exam. This one was a question about it. And the lateral plate give rise to what? Heart, blood vessels, blood cells, circulatory system. You know, most of things are coming from this thing. Okay. Let's look at the next question. Yes, doctor?
Making the verticulum originates from structure which connect the umbilicus to which part of GI tract? Midgut.
Midgut. Okay.
Option B.
Let's look at that. Yeah, that's correct, right? It connects it to the midgut. Okay, that's fine. Let's change the topic. I think that's enough with the pediatric. Okay, let's just take one more question. Okay, let's see this one.
A neonate presents with sudden onset of bilious vomiting, abdominal distension, and failure to pass meconium. Is suspected of midgut volvulus. Our GI series will typically show which of the following. It will show the DJ flexure to the left of the midline.
DJ flexure to the left of option B?
Yeah.
Are you sure?
No, I think I mixed it. Yeah, it's to the right.
To the right. This one. Option C?
Yeah.
Okay, let's see. That's the correct answer, right? So normally the DJ flexure is actually normally to the left, right? At the transpyloric
Yes,
plane, or
it
very
is
close to
another.
that. But when it is midline or to the right, that's not normal, right? That means there are other findings, you know, here in the explanation. The thing that I want you to know from this explanation is that they said upper GI series is the most sensitive thing. They said sensitivity, specificity, and accuracy is 93, 77. So all high. You don't have to remember the numbers, okay? So upper GI series is the best investigation to diagnose this problem. But it's only done in the hemodynamically stable. Okay, you can't do it in someone who's hemodynamically unstable. Okay. Yes, that's what I wanted you to know. The findings in malrotation include ligament of Treitz on the right of the abdomen instead of the left, a corkscrew duodenum, a duodenal obstruction with a peak-like appearance if a valvulus is present, if there's actual valvulus, okay? There may be also LAD bands associated with that. Okay, thank you very much, doctor, for participating. Anyone else would like to read? just raise the hand. Anyone would love to participate? Yes, okay, Dr. Anfal, you can unmute yourself and we'll start with another topic. We'll take head and neck anatomy. Yes, can you start, doctor?
Sorry. 50-year-old man present to a dentist with sensitivity and pain in the right upper teeth. Examination confirms swelling in the right cheek and maxillary sinus. And maxillary sinus infection diagnosed. This sinus is particularly prone to infection, and because of طيب absence helium epithelium. Yeah, position of the sinus ostium high in the medial wall.
Okay, yeah. So the position, that's the correct answer. As you can see in the diagram, this is the maxillary sinus, right? This is the other maxillary sinus. The ostium is very high in the wall. Do you see the opening into the nasal cavity? So there is some element of stagnation or stasis. Okay, let's look at the next one.
Okay, 45-year-old woman complain of numbness of the left side of her tongue following extraction of her left lower third molar tooth. Damage to which of the following nerve is most likely to explain this? Left numbness في left side of the tongue. Yes, this is an inferior alveolar nerve. Sorry. No. Damage to lingual nerve. Lingual nerve. Yeah.
Okay, let's see. Yes, the correct answer is the lingual nerve. As you can see, if you can see the diagram here, okay, that's the lingual nerve. This is the chorda tympani. They are joining together here. The lingual nerve enters lateral to the superior constrictor and then through the oropharyngeal triangle here. Superior constrictor, middle constrictor, mylohyoid, this triangle. It will enter very here, right? Very near to the insertion of the superior constrictor. And here it is very superficial under the mucosa, so it can be damaged with problems near the third molar. The next location, do you see this is the submandibular gland? This is the duct for it. It loops under the duct from lateral to medial direction. It loops under. So during mobilization of this duct, sometimes this nerve can be damaged. Okay. Let's look at the next one.
During routine eye examination, light is shown in the patient eye and pupil constrict normally. The second, optic cranial nerve and which other cranial nerve is involved in this direct pupillary reflex? Optic and oculomotor. Third.
That. Okay. That's the correct answer. It's option A. Yes. So we need to know, I want to add a note here in this diagram. Do you see these are two optic nerves and these are the two optic tracts? There are some fibers from the optic tract leaving it and entering directly to the midbrain. It enters into these two nuclei posteriorly. These are called pretectal nucleus. These two pretectal nuclei, they are interconnected with each other. And they are also cross-connected with the Edingarvist valve nuclei in front. Do you see? So it means that's why when I've seen a question before that they say, why if you shine a light into one eye, the other eye constrict? The reason, one of the options, is that it's due to the cross connection in the pretectal nuclei with the Edingarvist valve nuclei. So if one pretectal nucleus is activated, it's going to activate both Eden-Garvest-Val nuclei, right? That's the reason behind it. Okay. Let's look at the next one.
Which of the following statement is true about vertebral artery? It arises from thyrocervical trunk. It enters the foramen transversum as C6. It enters the skull via foramen rotundum. It is closely related to vagus nerve in the neck. Its supply. I didn't see.
Okay.
Last answer is supply the frontal cortex. My answer is B. It enters the foramen transversum at level of C6.
Okay.
Yeah.
Yeah, that's correct, right? It enters at C7. Of course, C7 doesn't enter through it. Okay. Yeah, can you read this?
27-year-old man is assaulted and sustained trauma to his face. He presents to emergency department with reduced facial sensation over the cheek, and on X-ray he has fluid level in the ipsilateral maxillary sinus. Injury to which nerve is most likely cause for paresthesia?
Okay, let's see the options.
Oculomotor, facial, infraorbital, mandibular, nasopalatine. Infraorbital. Yeah, C.
Yeah, so the infraorbital nerve supplies a wide area on the face, right? It is supplying the cheek, the side of the nose, the lower eyelid,
Cheek.
the upper lip, right? So there's, if they, in the scenario, they say there's extensive area of loss, and they describe this clearly in the distribution of the infraorbital nerve, then yes, that's going to be the answer, because it passes in the maxilla. If there's a fracture there, then it could be affected. Okay, let's look at the next one.
23-year-old man sustained trauma to left side of the face. After 2 weeks, he noticed that his left eye is dry and cannot produce tear. From which ganglion do postsynaptic secretomotor fiber arise to supply lacrimal gland? It arises from trigopalatine ganglia. Yes, D.
D. Okay, that's the correct answer. So basically, this explanation is just explaining in depth how the pathway of the lacrimal gland. I think you should take screenshot of this, guys. That's very important. Always explained, always asked about in the exam, repeatedly in every part of this, pathway. Okay, let's look at the next question.
A 60-year-old woman is found to have large, very vascular intracranial meningioma supplied exclusively by grossly hypertrophied medial meningeal artery. Which of the following skull base foramina is most likely to be large? Foramen spinosum.
Foramen, option E. Okay. Yes, that's the correct answer. I want to highlight something. Of course, they are asking about which foramen passes, but I want to also say what other questions may come. One question is, they may not just say it is foramen spinosum, they will just describe its position. They will tell you it passes through an opening in the undersurface of the greater wing of the sphenoid, posteromedial, for example, to the foramen ovale. Is that correct or not?
Correct.
No, it's not correct. It's not posteromedial. It's
posterior-medial. Yeah.
Right? It's
Yes.
posterolateral to the foramen ovale. So you need to know where's the opening and what its relation to the surrounding structures. It is immediately posterolateral to the foramen ovale, and it is in the greater wing of sphenoid, not in the lesser wing. Another relation, if we can zoom in here, this is the foramen ovale, is that right? And that is
yes.
the mandibular. This is the posterior division of the mandibular, and this is auriculotemporal. They always love to ask about this because auriculotemporal originate as two filaments which straddle or hug the origin of the middle meningeal. This is middle meningeal. So this is maxillary. This is middle meningeal artery. Do you see? It has very intimate relation with the
Yeah,
middle meningeal.
yes,
This is so
yes.
important. They always love to ask about this. Okay, let's see the next question.
A 20-year-old man is brought to emergency department with a stab wound to the left side of the neck. He has no stridor. His respiratory rate is 18 breaths per minute, pulse rate 90, and blood pressure 130 over 80. He has hoarseness of voice, and which of the following may have been damaged? Um, vagus nerve. Yeah.
Option E.
E. Yes.
Yes, the vagus nerve, because it is giving superior laryngeal. This is the vagus, right? This is the superior laryngeal. It has internal and external branches. You have to know that the internal branch is purely sensory. It doesn't give anything motor, okay? The external branch supplies this cricothyroid. The recurrent laryngeal is over here, so, in the chest, on the left side, and then it will supply all of the other laryngeal muscles. Simple as that. Okay, let's look at the next one.
A 19-year-old man is stabbed in the side of the face. In the area of the left parotid gland, it is suspected that the facial nerve trunk has been transected, which finding will support this diagnosis. Okay, cutaneous sensation lost on the left side of the face, movement of the upper part of the face is spared, mandibular salivary gland secretion diminished, taste sensation is impaired in the anterior part of the tongue, the muscle of facial expression is paralyzed. This lower motor neural lesion, the facial, and movement of the upper part of the face is bad. Interesting. Okay, E, the muscle of the facial expression are paralyzed.
Okay. Yes, so that's the correct answer. Simply that when it is lacerated in its extratemporal part, right? It's in the extratemporal part of the nerve that is outside the facial canal. Most of the functions proximal to that, of course, will be spared, including the taste sensation, chorda tympani, including muscle stimulation, lacrimation, also
Yes.
greater betrothal. All of that will be intact, but anything outside will be lost, including all of the muscles of facial expression, right?
Yes.
Okay, let's look.
Nerve to stapedius also it will be affected, or
No, it will be spared because nerve to stapedius originate within the facial canal, so there's no hyperacusis, right?
okay. 50-year-old man present with difficulty swallowing and alteration in his voice. On examination, there is a vocal cord paresis and absent gag reflex. There is also weakness of trapezius and sternomastoid muscle. A cranial MRI revealed mass lesion in the skull base, the most likely to involve okay, he asked about foramen. Foramen. This cranial nerve vagus glossopharyngeal and all go through the jugular foramen or yes, jugular foramen.
Yeah.
Vagus and glossopharyngeal, yeah.
Yes, so jugular foramen, right? The manifestations
Yes.
described are those of the glossopharyngeal accessory vagal. Okay. How much question? 10 questions. Okay. Now we will move to something important, which is a little bit difficult. I just want to look at it. It is surgical technique technology, biostatistic, micro. Okay, where is it? In the physiology and disorders of coagulation, right? Okay. Yeah, go ahead, doctor.
Okay, I continue.
Yeah, continue.
One Willebrand factor is involved in stabilization of which of the following clotting factor listed below. One Willebrand. Okay, I didn't see the last one. Sorry.
Here it is. Can you see?
Factor 10. Okay. One Willebrand factor. Factor 8. Yeah.
Okay. Let's see.
Yes.
Yes, so it is involved in the stabilization of factor 8. That's why those with von
Factor 8.
Willebrand,
Yes.
yeah, those that are involved that have von Willebrand disease, they have prolonged PTT, right? Because of there is
Yes.
destruction of factor 8. In addition to having prolonged bleeding time. Okay. Yes, doctor.
45-year-old male had alcoholic cirrhosis and decompensated liver failure. Which of the following clotting factor is least likely to be affected? Mm, factor 8, yes, because produced by hepatocyte and
sinusoidal cells,
I
right?
think
Some
yes.
doctor on this chat said any new study about hemophilia increasing bleeding time? Yes, right? Well, it is classically that they say bleeding time is normal in hemophilia, but now there's a study in PubMed, bleeding time is increased in hemophilia. Anyway, so let's look at the answer, factor 8. Yeah, so that's important explanation here. They said one of the organs intimately involved in the coagulation process, the liver. The liver synthesizes what? Factor 1, 2, 5, right? Factor 5, 7, and 8. But look, 8 is not from the hepatocytes. It's from the endothelial cells, that is hepatic sinusoidal cells. Okay? So the liver does produce factor 8, but not from the hepatocyte. It's from the hepatic sinusoidal cells. Factor 9, factor 10, factor 11, factor 13, and protein C and protein S.
Yes.
Here it is saying, again, factor 8 is created by the vascular endothelium. The liver does not produce factor 3, which is tissue factor, and factor 4, which is calcium, right? Factor 4 is calcium. Okay.
Which of the following statement related to coagulation cascade is true? The intrinsic pathway is the main pathway in coagulation. Heparin inhibit the activation of factor 8. The activation of factor 8 is the point when intrinsic and extrinsic pathway meet. Tissue factor released by damaged tissue initiate extrinsic pathway. Convert plasmin to plasmin thrombin. Yes. I think thrombin convert plasmin to plasmin.
Option E. Okay, let's see the answer. Thrombin converts plasminogen to plasmin. No, that's incorrect answer.
Incorrect.
It says correct answer is option D, which is tissue factor released by damaged tissues initiates the extrinsic pathway. Yes. So thrombin
Yes, okay.
converts fibrinogen into fibrin, but does not convert plasminogen into plasmin, right? Plasminogen is converted into plasmin by tissue plasminogen activator, right? So, okay, it's okay.
Right.
So tissue factor activates factor 7, and then factor 7 activates factor 10, and so on. Okay. Let's get the next question.
23-year-old man present with apparent abdominal trauma and splenic bleed is suspected. His comments on infusion of tranexamic acid, which of the following best describe the mechanism of action? Inhibit plasmin. Yeah.
Inhibition of plasmin. Tranexamic acid is so important to know about. Yes, it is an inhibitor. It actually inhibits plasminogen as well as plasmin, right? The active form.
Yes.
And also, it does reduce, the conversion of plasminogen into plasmin. The important note here, look in the explanation. That's so important. So it says, number 1, tranexamic acid is an analog of lysine. That was a question in May 2024, right? Tranexamic acid is an analog of which amino acid? Remember, it's lysine, okay? The other important point in this explanation, it is saying, yes, it is given routinely in the bleeding trauma patients. All bleeding trauma patients. You don't have to remember the dose. It says 1 gram is given over 10 minutes, then 1 gram over 8 hours. But you should give this, look at the next one here. It needs to be administered as early as possible, and ideally within the first hour. The first dose should not be given more than 3 hours. That's very important. Meaning, if the trauma event was more than 3 hours ago, you cannot give tranexamic acid. It's contraindicated because for an unknown reason, it causes, paradoxically, it increases bleeding. Okay, so that's extremely important to know about. Okay, guys, I think we can take a break now for about 15 minutes, okay? And then we will continue more with coagulation. Then we'll move to something else. I will then post another meeting link in the group, okay? So I will see
Thank
you.
you. Okay.
Thank you, everyone. Thank you so much. I will see you in 15 minutes. Thank you.